Great. Thank you all for joining me. I get the privilege of speaking to you about frailty, something as a geriatrician I love to learn about and talk about. I hope to be able to give you some definitions about frailty, a bit of an understanding of why we should identify it, how it's a very important predictor of outcomes and function, and that there are things to watch for and potentially modify so that we can look to improve outcomes in our populations, and try to give you a bit of a structured approach or unstructured approach, whatever fits for your practice, to use for your patients. So this is my name. I don't have any financial disclosures because who has time these days? And so here's my case, and I can't even take it. I can't take credit for this case. This is Sherry Lynn Kane, who's my favorite geriatrician of all time. Speaking of distilling the important points. So this is a spot the frail patient. So these are two individuals. You're in the emergency department in this case. And in one bay, you have an 80-year-old gentleman who is a non-smoker, and he has just returned from a scuba diving expedition. And he's coming to the emergency department with a 2-hour history of chest pain and shortness of breath. And in your next bay, you have an 81-year-old woman. She lives in her own home. She has a history of severe osteoarthritis, maybe a bit of short-term memory loss, and she has been housebound for the last 3 months. And if I had done this with COVID, I would have said housebound for the last 18 months. She has a 2-day history of confusion as reported to her family by her PSWs. Her PSW noted when she arrived today, she was a little bit more confused. And so she went to the emergency department with confusion. And what is nice about this case is that both of these individuals are the same age. So that is the same about these two individuals. What else is the same about these two individuals is they are both presenting with a myocardial infarction. What is different about the two of them is one is frail and one is non-frail. So when we talk about frailty, why is it important? And many of us will say, you know, I don't really know what it is, but I know it when I see it. And so these could very well have been the two different people in two different bays. You get a sense that the gentleman up top is vital. He has some muscles I can see. He's in the sun, probably a lot of vitamin D, maybe just went for a run on the beach. And then the gentleman underneath who has a little bit more squaring of his shoulders, maybe a little bit less muscular. It has a bit of an institutional feel. He has an evidence of disability in a wheelchair. And maybe a bit kind of depressed and isolated. And so has it could actually be the same person, which was not intentional, but you can tell the difference between frailty and not frailty. And so there is a consensus. Used to be, it was hard to get consensus, but there is a consensus statement about what frailty is. There's agreement that it's a syndrome rather than a diagnosis necessarily. So a syndrome is something with multiple causes or multiple risk factors or contributors that result in this syndrome. So this syndrome is characterized by diminished strength, endurance, reduced physiological function, and really reduced physiological reserve. So it increases an individual's vulnerability for developing increased dependency or death. So that's a consensus statement for what frailty is. More generally, it's really the chance that the wheels are going to fall off because now there's so many problems, there's just no more room for error. So is the other way to kind of think of it. So it's this person. So this person is also kind of a nice indication of what frailty is. You know, this person is managing in a day-to-day environment, actually performing a rather heroic feat. But a lot of things stacked against him, so to say, such that even a rock on the road, a bird landing, a gust of wind is going to just result in calamity, which is what often we see with our patients. So this is a nice graph. Can you see my arrow if I do this? Yeah, I can point. Yeah. So this is a nice graph that kind of indicates what, function on one graph, and then a responses to a stressor and on the other. So this is someone who's moving along. So non-frail people can move along doing reasonably well at a certain level of function. They get a stressor, they lose a bit of ground function-wise. Maybe you land up in bed for a few days, you get a cold or a pneumonia, or you have your appendix out, you shake it off and you get out a couple of days later and you're right back to where you were. So if you have a bit of mild frailty, you're going to have, again, maybe a more significant deterioration in your function. It's going to take you longer to recover, and you may not quite make it to baseline. Once again, you may lose a bit of ground. And then severe frailty, someone who is more severe, you can actually have the same stressor result in a much more significant loss of function, a much more prolonged course to recovery. And again, you may not quite make it to baseline. And so ultimately, this is what I see as what's wrong really with our hospital system at this point, in that we expect everyone to behave this way, where you get a pneumonia, you bounce back and you're out within your expected length of stay of 5 days, but we're not taking into account our increasingly frail population who have a much more significant result of functional decline and take a lot longer to recover. We haven't quite sorted that out yet. So we know it's not simply aging, because we know of people. I just showed you the runner. There's actually a 90+ section on the London Marathon. So we know there are people who age and who are not frail. We know that frailty is not the same as disability. I mean, we have Paralympics, for example. So we know lots of people who have disabilities who are not frail, and we would not dare call them frail. And we know it's not necessarily the same as chronic disease or necessarily chronic itself, but aging will increase your likelihood of becoming frail. The more disability you have, you might have a higher risk of having frailty, and the more chronic conditions you have, that is highly associated with frailty. And they are related to one another. And so you can't really treat one without taking into consideration the others. We know it's a dynamic balance of multiple assets and then deficits. So what your health is like, and potentially what your health and your health practices have been like lifelong, will contribute to your ability to be frail or non-frail. What are your resources? What can you build in your own home? Informal resources, financial resources. Are you someone who takes health and wellness seriously and make sure you're always exercising and making good choices? Do you have a caregiver? That can make a big difference in terms of how frail you are. And then what are the things working against you in terms of socioeconomic burdens, dependence on others, illness. And we can see that you can have predisposing factors, enabling and reinforcing factors. So this is this concept of a syndrome. We know that frailty is a geriatric syndrome, in that you have multiple risk factors that can contribute to the composition of frailty. Now, we have a number of geriatric syndromes that we talk about in geriatrics. I'm sure some of which you've spoken about during your sessions: falls, delirium, functional decline. And they all have multiple risk factors that will result in the syndrome. What's kind of nice about, or handy for those of us who do geriatrics, is they tend to share the same risk factors, generally speaking, in that muscle weakness, multiple medications, dehydration, cognitive impairment, age, hearing impairment, vision impairment, really all can result in a fall. They equally will predispose you to delirium. And all of these risk factors, and also having these geriatric syndromes, can culminate in frailty. And all of these geriatric syndromes and frailty itself are very significant predictors of disability dependence, long-term care admission, and death, in fact, more so than age. We do know it's changeable, so it's not necessarily a dismal and predictable state. So we have had studies that have shown us that frailty can be dynamic to a certain extent. And although if we measure everyone at point A and then measure them 10 years down the road, you'll likely see a progression of frailty, an increase in frailty. But if you actually measure people more frequently in between, as this particular group has done, what they'll see is that transitions of states between frail, non-frail, pre-frail actually occurs rather frequently. And while transitions to states of greater frailty is more common, you do get about a quarter of the time transitions to lesser frailty. So there is opportunity for intervention there. And so this is just a bit about prevalence. I just updated this slide because I thought, well, we should probably get some Canadian and Ontario data. So this is actually the Canadian Frailty Network estimates that probably 1.6 million Canadians are medically frail. And the Provincial Geriatrics Leadership Office has recently done an analysis that suggests about currently 450,000 Ontarians are living with frailty. And so those are the prevalences, again, going up with age, but just to draw your attention that this still means that 50% of people over the age of 80 are not frail, just to look at it as a glass half full. It does depend on age and setting. And so up to 90% or so of people in long-term care would be considered frail by definition. We do know that if you're frail, you're at higher risk of dying, of having functional decline in caregiver burden, of being hospitalized, and you are much higher likelihood of utilizing healthcare. It's more predictive of postoperative complications than age, and very much predictive of an atypical disease presentation. So what I showed you earlier, in that someone who's frail doesn't necessarily read the textbook and give you the chest pain radiating down the arm. They can just present as confused. And this has remained true in the setting of COVID-19. So people presenting with just delirium and testing positive for COVID-19, we have seen that in frail individuals throughout the pandemic. When you're measuring frailty, there's different ways of measuring it. Probably if you search this on PubMed, you'd get hundreds of different ways to measure frailty. We're going to look, this is the common phenotypic definition. And if you go to the Canadian Frailty Network, they will kind of define it this way, saying these are the 5 things that tend to be consistently shown amongst people who are frail. So typically you will see weight loss. They tend to have had weight loss. There are ways to define it formally for research purposes, but if you can just ask folks if they've lost weight in the past year, there tends to be associated with weakness, often measured by grip strength. Interesting study I just found, actually, it was just this month in JAGS, where people with COVID-19 infection, if they're 8 months later, had a significantly reduced grip strength. This is people that were infected. So this was shown more if your infection was more remote than more immediate. So they think it's more of a chronic finding. So there might be something that happens with these infections. And we see this with the flu and influenza, where there's a high association with frailty after infection. So there might be a direct actual effect on skeletal muscle function. So grip strength is a big predictor of frailty. Poor endurance is common. People will say, I'm just fatigued. I just don't have the same endurance I used to. And it's not necessarily related to cardiac or lung function. They are slower, as defined by walking speed. And they tend to have social isolation, physical inactivity, tend to just keep to themselves. And so that is a classic phenotypic definition of frailty. And this tends to be seen in most folks who have frailty. Many of you probably have been familiar with the clinical frailty scale. So this is more of a clinician's impression of frailty. So what you might get from learning about your patient and asking them about how they're functioning. This is developed by Ken Rockwood. And if you're a frailty scale of very 1, you're very fit, you exercise regularly. If you're a 3, you're managing well, you have medical problems, they're well controlled, but maybe not regularly active. Vulnerable is you're starting to get more slowed up. Mildly frail if you're starting to have more help with your instrumental activities of daily living. Moderate if you're needing help with your basic activities of daily living. And then severely frail and onwards. So this was shown very early on that each 1 category increment increased your 5-year risk of death and institutionalization. So even this fairly, I would say, much less specific way of measuring or assessing frailty seems still to correlate very well with the outcomes that we were just discussing. Some days I'm a 4 or 5. So kind of depends on where I'm at. Some days I'm a 2. I also transition between states of lesser and greater frailty. So the big question for us is it reversible or preventable? And so there is some hope. So these are some warning signs. So this is a great resource. The website is at the bottom of the slide there. that this is from BC, and I've actually attached some of the resources at the end of the presentation, which I likely won't get to because I talk too much, but it outlines different warning signs, tools, things to incorporate into your practice as primary care. So it's a frailty approach in primary care that the BC government has developed. But there are some warning signs, so things to pick up on in your office that will make you really think about frailty as if they're losing weight. So if you're measuring weight every time, if they're newly incontinent, if there's a history of an admission with delirium, they're starting to have some cognitive impairment, they're starting to need a bit more help with their ADLs or IADLs, if they're not walking around very well, if they're presenting with a fall, or you're noticing they're very susceptible to medication side effects. These are just some signs that they may have frailty. There's others there, but those are the most kind of potent. And there's clear studies to show that interventions work to reduce functional decline in frail older adults, which is really what most people are interested in, is preventing functional decline. So exercise, it works. It doesn't matter where you are on the continuum. If you're cognitively impaired, if you're in long-term care, if you're frail or not frail, home occupational therapy with exercise can improve function, medication reviews, and then comprehensive geriatric assessment, where you're looking at all of the particular things that might impact your day-to-day function, and how we address some of those risk factors can result in better function, which is a surrogate for frailty. So for those of you, I'm not sure if we've had a chance to go through CGA, but a CGA is just a fairly comprehensive approach to the assessment of an older adult. It goes beyond the medication review, past medical history, and current history of presenting illness, but we'll also make sure that we review mood, cognition, physical status, mobility, gait, function, goals of care, and then some common, have you fallen, do you have trouble with continence, bowel, or bladder? So just to address all of these things, because they all might actually matter or be contributing to the problem that you're trying to solve. And so while this can be overwhelming, and I think this is important because I worry that in geriatrics, we do a really good job of making things so complicated, no one can do it or want to do it. And I worry about that. I think if you're faced with where do I even start, I find figuring out where people are at is a good way to kind of frame or prioritize where you start. Because at the end of the day, most people want to be functional and independent and symptom-free. And so tell me about your function. How do you get up and get dressed in the morning? How do you do your instrumental activities of daily living? How do you live your day-to-day life? And what has changed? And so when did you stop being able to get dressed? And so when did it become more difficult for you? Oh wait, you blister packed your meds. Why did you do that? What was happening? So why did you start doing this or stop? And when did that happen? And that can help you establish a bit of a timeline. I always say in geriatrics, it's not like pediatrics where you have these like growth curves and at 18 months, this should be happening. If you're not here by 20 months, you need to phone a friend. It's more, well, what could you do before? Why can't you do it now? And why? Tell me about that. And then what's the reason? Is it because you're dizzy when you stand up? Or is it because of your knee pain? Or is it because you're depressed and your wife died and you're lonely and maybe she did it all this time? Or is it because you can't remember? So let's look at that and figure out what it is that caused that change. And so this is where I say it's important to focus. Although we throw all these domains at you for assessment, it's really important to focus on the forest and not the trees. And so what is the syndrome it's resulting in? It's resulting in falls. Well, let's talk about that. Or it's resulting in me not being able to do these things. Well, let's talk about why that is. It's important to know that patients can do this. They don't talk about a diagnosis. They talk about what is happening. And they're able to understand that not all things are solvable. This is a generation that doesn't really expect us to solve everything. They understand that I might actually make something worse if I treat this thing. So let's talk about what's most important to you and what matters most. Because if I treat this, I might make this a little bit worse. So let's talk about, is it living longer? Is it being symptom-free? Is it being independent? So those are things that kind of help ground the conversation. So there are ways like checklists that can help you if you're seeing frailty. Things that are pretty easy. We should be vaccinating because these are, I've talked a little bit about how inflammation or can cause functional decline. So let's not, avoid pneumonias, avoid the flu, avoid COVID. How can we maintain cognition? So physical activities, stroke prevention, make sure that we're recognizing any of these risk factors in geriatric syndromes as an opportunity to intervene and maybe do a more comprehensive assessment and deeper dive. Make sure we're optimizing comorbidities like depression and pain, vision and hearing that might be impacting their ability to function. And is it financial? Maybe it's a social worker you need to engage. Exercise across the board, so important. If only that was in a pill, it would be so much easier, but it really is one of the most important interventions we can do. Nutrition, hydration, and a medication review with a particular eye on psychotropics, blood pressure pills, orthostatic vitals, and then optimizing the environment with caregiver and community support. So if you can't fix it, can we bubble wrap it, right? It's kind of the other approach to geriatrics. Yeah, so that's the most of the presentation. These are, again, just some of the tools. This is from that British Columbia website. There's actually a sample care plan template for primary care, which I find very helpful, that you can bring this into your EMR, comorbid conditions, goals, preferences, frailty scales, care plan documentation with your medication review. It talks about all the different systems, and this, it is, again, a bit overwhelming. But it actually gives you advice on how to do rolling visits and how to do some questionnaires and send stuff to caregivers ahead of time to try to pull all this together in a more timely manner. Yeah, so I'll leave it there.
Amazing. Wonderful. Terrific. Great. We're done.
Was I okay for time?
It was perfect for time. I didn't look at the clock. So yeah, whatever it is exactly what it was. So that's perfect. Yeah.
I will unshare. Is that what I have to do?
Sure, you could leave that on while we talk too, but I love all the tools are very nice. What is this one?
So this is from the Canadian Frailty Network. And so it is lovely as well, because I find this one more patient oriented, or at least accessible, I would say. I think it's great for clinicians. I learned things on it. It has nice little acronyms like how to avoid frailty. And then of course, A is activity, V is vaccinate. And so this is a lovely brochure that you can use, but on it is as well resources. So if you go to activity, it clicks, and there's actually all these different activity packages on, so we use some similar things when people were housebound from COVID and we didn't want them getting deconditioned. There's actually some very accessible exercises that are in there. So lots of different resources that you can use for your patients.
Wonderful. So perhaps I'll ask you to stop sharing. We can open it up to our participants. Any questions, comments, observations? What I might do is, if I can ask folks who are able to and willing to share their video, it would be lovely to see as many folks as we can as well. Thank you. Can I get us started then, Joanne, and ask a couple of questions? So I'm really impressed by the literature that points towards the importance of grip strength. And yet it's not really part of what we typically do in the family medicine office. So I'm just curious, does anybody use grip strength? Do you use grip strength? How does that actually work?
So two things. I have terrible grip strength suddenly and can no longer open jars, and that makes me terrified. So I hope it doesn't mean too much, because otherwise I'm in big trouble. I think it's arthritis, but I actually also just bought a grip strength monitor, not because I use it in my clinical practice, but I do TAVI assessments, and part of it's incorporated into some of the tools, and I find it's nice to use concrete numbers. And so we actually did just buy it, but no, I don't incorporate it routinely. I think it's more for research purposes. I think it's a surrogate for strength and functional strength. I think, in that it's your hand strength. I think that's useful, but no, I don't use it. I feel like it's weakness. I wonder, like, you know, I find what's more useful in terms of showing strength, and I'm sure all of you folks do this, is cross your arms and get out of a chair, right? So can you show me, I want to know what your lower extremity strength is like. But I actually do think both are important for probably similar or different reasons.
Does anybody use grip strength, or is there some other measure of, as a proxy? I have to say I do the same as Joanne. I have people stand from a chair sort of as many times as they can in 30 seconds and count that. And then I have them grip my fingers as hard as they can. And I say, please try and break my fingers and see. Yeah. But do other people do anything? And the other one is, just in the Freed phenotypical frailty measurements, looking at activity level. And I saw that the scale was on calories burned, but who knows what that is. So I'm just curious about how you question people about activity level and energy.
That's to me probably. Eh?
Yes, please.
I actually don't. I actually don't incorporate that regularly in a quantifiable way. I regularly ask people, what do you do for physical activity? How do you stay busy? And I just in my own mind differentiate between folks who say, oh, I do lots of exercise, I do laundry, I make my dinner, and then versus those who I go for a walk every day, or, you know, and then others who tend to watch TV most of the day. So I actually don't quantify it in that. I think if I did research, I would, but for me, those are kind of my tiered system approach to physical activity.
Thank you. Aileen, I see you made a couple of comments. Do you want to speak to them?
I often have a hard time with fatigue because everybody seems to be tired, and they're more tired since COVID. And how much is frailty? How much is psychological? How much is just life? That it's something I find hard to measure. I don't see many people saying they're not tired.
How do other people approach that? Amanda, I see you're nodding. You're on mute. Hard to unmute. Eh? Yeah. I guess getting back to Joanne, your thoughts around what it is now compared to what it was before. So I'll sometimes ask, are you more exhausted than you were the last time we saw each other? Or are you the same, or are you less exhausted? And trying to give them all of the options available. So I'll try and frame it as a scale.
I actually use a counter approach in an outreach situation. So we ask the patients what they do to counteract fatigue. And what you get is a really quick understanding of their knowledge base around what creates fatigue. So sometimes people don't realize the relationship just between basic physical activity or basic nutrition or basic emotional, you know, discourse in mitigating fatigue. So we ask, do you have a plan for counteracting fatigue? And you learn a lot asking that question about people's knowledge base around what would be useful. It's like counterintuitive to think if I'm tired, I should just sit in my chair. And so sometimes we broke the fatigue cycle just by getting people to commit to a 10-minute walk every day with their partner. And so it's like giving them options.
Great strategy. Love that. Any other questions for Joanne?
I just had a comment if it's useful.
Of course, yeah.
I really valued the way you repeatedly went back to the patient's story. And I teach in a college, so a couple of my students are working with an electronic database to try to make a face page for hospital records where a patient's personal story can be told and updated. And I'm just curious about, the state of affairs in your individual worlds, I'd love to see a chart where that personal story was up front, especially in frail elders, but honestly with every single patient. Here's who I am, here's where I came from, here's where I'm trying to go. And these are my particular barriers, including, like, there's some brilliant work done at U of T looking at, health disparity and how you evaluate that with the patient and social determinants of health. So I find it, when you go to a medical record, the last thing that you can find is a comprehensive story. And so we all start at zero and try to figure out what's going on.
We know that frailty, for example, is 3 times as common in people in the lowest socioeconomic quintile, just as one example. So these things are, and a lower education level doubles your risk of frailty. So there are all sorts of different correlates. You're absolutely right, Susan, for sure. Yeah, great comments. Thank you. And I love, Joanne, how you took that overwhelming, impossible to do unless you're geriatrician, comprehensive geriatric assessment. I'll never have 3 hours in the office with somebody. And you distilled that down for us into sort of what the key priorities are. So sort of to focus on the function, to focus on goals, maybe to look at what some of the resources are that people have that they can, what cards do they have that they can play, and the idea of what's changed, when did it change, why has it changed. I really love that as a really practical approach. So you can forget 8 of the 27 things on the CGA, but if you remember those principles, then you can sort of apply it in the real world. The other thing I'd say in primary care and family medicine is to get ourselves off the idea that you have to do it all at once, right? So you can see somebody, once a month for 20 minutes and do all of this over the course of a year and get a real sense of where people are. So pick and choose, I think, can work really, really well. We're all very capable of doing this. Anything else that we want to talk about more generally, and then we can go on to our case?
No.
Go ahead, Susan.
Yeah. Okay. Yeah. I just think what is very helpful to prioritize. Do I pronounce it right? To set priorities. So if you say it's most important that you start exercising, right? This is one very strong message, which will hopefully stick. And then maybe even 2 or 3 other recommendations might kind of make it all a little bit blurry and nothing will be implemented.
If you try and make everything a priority, then nothing is a priority.
That's exactly what I mean, right? And when you say maybe we shouldn't address everything at once, that goes in the same direction, right?
Yeah. And then putting together your comments with Susan's comments with a patient-centered lens, so they get to pick what the priority is, and then it's our job to help them to achieve that priority. Right. David, you had a comment?
Oh, I was just going to ask John about gait speed, because you had that listed, and I know there's a strong association between gait speed and mortality. There's obviously different ways of measuring it. I know there are standard ways, where you can actually measure it with a stopwatch and so on. And does anyone use that approach, or is it just, maybe on a 5-point scale? How do you evaluate gait speed? It's one thing you can measure just as the patient comes into the office, right? It gives you quite a bit of information even before you've started.
And before Joanne, you commented, does anyone else approach gait speed in any particular way? Joanne, how do you do that?
So yeah, we have a chair in the hallway and a piece of tape, and we do a timed up and go. I wouldn't say we don't do it at every visit. We do it the initial visit and then kind of as needed. It's nice though sometimes, because I've had the opportunity where we weaned someone off of benzodiazepine. It's really nice to be able to say, look how much faster you're walking now. It doesn't always reflect on the cognitive testing, or they don't always necessarily perceive the benefit. But gait speed is a really nice one to be able to have as an objective measure. Also using a walker and not using a walker. So, because a lot of folks are nervous, they don't want to use a walker. That's for old people, even though they're 89. I don't know when the old people, I don't know when that arrives for you once you're 89, but nope, that's not for me. But if you can show them how much faster they're walking with that, to me, it's always about the hook. Like, how can you, whenever I see a patient, to me, it's what's, what was the family physician's goals and sending them to me? What is the patient's goals? What's the caregiver's goals? And what's my goals? Because they may align, but they may not. But they're all important. All of us have something to add to this encounter. But at the end of the day, it has to meet the patient's goals. There has to be a hook for them to buy in, whether it's exercise or medication reconciliation or weaning down. If they don't perceive a benefit to them, they're not going to put in that work. And so for the walker piece, it's always like, you can actually exercise more. You can get there faster. I actually think you look younger because you're going more faster, you're walking straighter, So the gait speed to me, I think has a lot of value in different ways.
Great comment. Yeah, I think it's about a meter per second that we're looking for as kind of a target threshold, Dave. So in my office, the printer just happens to be 5 meters away. So I asked them to walk to the printer, and then I time them to see how quickly they can get there. And it can be a practical approach. Can I ask? I know we've got a bunch of.
I was just going to say, and since we all have iPhones, we all have stopwatches now, which wasn't the case before.
Right. Exactly. I have to apologize for the barking puppy who just woke up. I'm sorry about that. So can I ask, I know we have folks from very different disciplines, interdisciplinary. Can I ask you to put in the chat? Don't click enter yet, but type into the chat one thing that you can do from your perspective, from your discipline, with your experience, one thing that you can do to help patients who have frailty. And then I'll give you a few seconds to type something in. And then I'll tell you when to click, and then we'll see what shows up. And you can feel free to type in, leave me alone if you want to. And while you're doing that, oh, Shane, you've put in a comment. What's that about?
It's very timely. I was in a meeting earlier today and somebody was commenting about a new, new to me, perhaps not new out there, but frailty screener for primary care that Linda Lee and pharmacists had recently put together. It was the first time I was hearing about it, and this article was shared in the meeting, and it talked about grip strength and gait speed. So
great.
I've just shared the link there.
Oh, wonderful. Thank you. Okay, so click enter and see what came up from people from their different perspectives. I'm curious. So we've got patients, we've got exercise, medication optimization, physio, mobilization. Wonderful. Yeah. And being proactive. Yeah, I think those are wonderful comments. The thing about these syndromes is that they're all inputs, right? They have so many different inputs. So each of us can attack them from a different perspective, and then collectively we can make a big difference. And again, the luxury of being a family physician. I saw a 1-year-old yesterday, right? In the office, and I had the after hours clinic, and we were actually, the mother and the grandmother were both there. And we were talking about frailty and how do you keep a 1-year-old from becoming frail? It was a really interesting question. Because we have this arc of 80 years. It's really, really something. So, and Susan, education for sure. Okay, so with that, thank you. That was, I really enjoyed the discussion. Can we move on to Ambika and our case, please? Thank you.